Great. So we're going to go ahead and get started. Thank you, everybody, for joining us tonight, joining UW Medicine and the Office of Healthcare Equity with our continuing conversations tonight. We will be focusing on vaccines for children's ages 5 to 11. I'm going to turn this over to Dr. Chopra, who will be moderating the session, but thank you so much for joining. And please feel free to enter questions using the Q&A function down at the bottom. Thank you.
Thank you, Priscilla. Good evening, everyone. Welcome to this edition of Community Conversations hosted by UW Medicine. These conversations are an effort to bring our community and our patients closer to our experts. Especially during the pandemic, this is an opportunity for you to ask the most burning questions from our experts who are physicians, researchers, and leaders in public health. It is an honor to have a distinguished panel with us today. We have Dr. Waning Gupta, a physician scientist, a global health expert, a health care advisor, a health policy advisor, a military officer, and an eminent speaker. He is also a highly trusted source of information on media outlets and social media. Dr. Gupta is an affiliate assistant professor of health metrics sciences at the Institute of Health Metrics and Evaluation at the University of Washington. He is a pulmonary critical care physician. Dr. Gupta's research has focused on several important issues in global public health. He holds an active commissioning as major in the United States Air Force Reserve Medical Corps. He's also the senior principal health at Amazon. He has worked worldwide to improve public health, including the US Centers for Disease Control, the Harvard Global Health Institute, WHO, and the Pentagon's Center for Global Health Engagement. We are proud that he's part of us at UW Medicine. Thank you, Dr. Gupta, for joining us. We also have with us our very own Dr. Shaquita Bell. Dr. Bell is professor of pediatrics and the interim senior medical director at the Odessa Brown Children's Clinic. She is a beloved pediatrician, a committed patient advocate who has worked extensively towards healthcare equity and vaccine equity as well. Thank you, Dr. Bell. And we are also honored to have Dr. Nandita Mani. Dr. Mani is an infectious disease physician and associate medical director, infection prevention and control, UW Medical Center, Montlake and Northwest. A researcher and an author, Dr. Mani is passionate about infection prevention, antibiotic resistance, and community outreach. Thank you, Dr. Mani. I'm also joined by Priscilla Estrada, who is the communication and workforce engagement specialist at UW Medicine. Thank you all in the audience for joining us today on the recently approved COVID vaccines for kids 5 to 11-year-old session. And we have gathered community questions. We will be asking our experts those questions today. And I will start off by asking Dr. Gupta. Dr. Gupta, one of the questions that we've received is, why do kids need a vaccine with 90% effectiveness for a virus that they have a chance, 99% chance of surviving actually? Why do they need the vaccine?
Well, first of all, Dr. Chopra, thank you for that really kind introduction. It's great to be here with you and my distinguished panelists, Dr. Bell, Dr. Mani, Priscilla, thank you for the invitation. To answer that question, and I defer to the fact that Dr. Bell is a pediatrician, and certainly Dr. Mani as an infectious disease physician, all well placed to answer all these questions. But in my view, as a father to a young child, it's clear that COVID-19 poses one uncertainty to children in terms of whether or not it could cause serious illness. It's just unknown and it's very uncertain. There's an unpredictability to it and how it behaves if there's an exposure amongst a child, for example. So that one, there's that unpredictability. I'll say, just looking at the numbers as a dad, it struck me as really unnerving to see that between August 1st and September 15th of this year alone, 60,000 pediatric hospitalizations occurred as a result of the Delta variant. And if you compare that to the fact that in a bad flu season, we might see 20,000 pediatric hospitalizations in any given bad flu year, that tells the story right there, that we would readily vaccinate our children for flu in most cases. I'm assuming for many of the audience here, the decision to vaccinate your child for flu is not a debate at all. When you look at those numbers, that tells you that there is a clear and present threat to the health of our children. There's an unpredictability to it. And we're just learning about the more longer term consequences of the ways in which COVID can really impact children and their longer term development. This concept of long COVID that I'm sure a lot of us have heard about, it's a medical mystery to some degree. We still don't know a lot about the natural history of this long-term disease that seems to affect younger people, those that are just beginning in their life. And so when we see that vaccination predicts against the shorter term acute consequences of the virus ending up in the hospital, and also guards against this mysterious, more chronic phase of this illness that we're just learning more about, to me, the decision is a slam dunk to get your kids vaccinated, especially when you look at the safety profile of the reduced dose Pfizer vaccine, which is the only emergency use approved vaccine for children. Extremely safe, no issues with myocarditis or any of the other common side effects we've been hearing about in those that have been studied, but extremely effective, to your point, Dr. Chopra. So to me, this is a slam dunk to get your children vaccinated, but of course, defer to your individual discussion with your pediatrician.
Dr. Bell, would you like to chime in as well on this?
Yeah, I mean, I think Dr. Gupta covered it really well. You know, the other thing I'll add is, you know, statistics are really important for us to understand what a pandemic means, or when people are using language on TV or on social media that we don't understand. But the reality is your kid is your kid, and statistics are, you know, 99% is great unless your child is in the 1%, of course. We have seen, as Dr. Gupta mentioned, we've seen an increase with the Delta variant of kids getting sick. It does appear that the Delta variant is more likely to infect kids than the previous versions of COVID. And we have had deaths, even here in Seattle, of children. So I think we talk a lot about statistics, and we think a lot about statistics when it comes to safety and when it comes to risk. And it helps us think about it. It helps us sort of understand what risk is, because it's really hard as human beings to put risk into our mind unless a tiger is literally coming at us or a fire is literally coming at us. But all of the things Dr. Gupta mentioned is the reason why is we don't have to wonder about what if. We don't have to worry if my child will be the child that gets the multi-system inflammatory disease or gets long haul COVID. The vaccine prevents against all of that, and it's very safe and it's very effective.
Dr. Bell, would you like to talk a little about long COVID symptoms in kids, and what have you seen in terms of your patients? Is that a phenomena also seen in kids?
Yeah, we have seen long haul COVID. As Dr. Gupta mentioned, we don't really understand it very well. I think the hard part about long haul COVID, both for adults and for kids, is there's nothing we know right now to say this person's going to get it, or this is your risk factor for getting it. It's really hard to predict that. I will say the symptoms that we've seen in children are pretty similar: the loss of smell and taste, and then fatigue. And the other thing we worry about in kids that we've only seen in children is the multi-inflammatory systemic disease. I don't know why it's having a hard time saying it, maybe because it's a bunch of medical words, but that you'll hear it on the news as MISC. And that's really unique to children. We don't really understand why. Again, there's so much about COVID that we're still learning, but it looks like kids are at risk for this condition. And again, the vaccine is a way to prevent that. So we know that both long haul COVID and MISC is prevented by the vaccine.
Thank you. Dr. Bell, I'm going to ask you a little bit about the trials. Can you please talk about the trial? How many kids were enrolled? What were the steps in approval? And why does it seem like a very speedy thing? Was it something that was done, were some steps missed? Was there something that was not covered in the entirety?
Great question. So first, let me start by being completely transparent. I enrolled in a vaccine trial pretty soon after COVID started. As a Black Indigenous woman, I felt like it was part of my culture to be able to serve others and to protect my community. And I wanted I wanted us to know how the vaccine would react in a body such as mine. So how do people who are Black and Indigenous tolerate the vaccine? So I'm actually in the AstraZeneca vaccine trial, which is not a vaccine that's available in the United States, but it is the largest vaccine in the world that's being given to people. So I got to experience, and I'm still experiencing, a vaccine trial up close and personal. So that's why it's really easy for me to talk about it. The trials started off in adults, as we know. So they enrolled thousands and thousands of people. Each company that wanted to create a vaccine did this. You go in, they give you a lot of information. I'm talking hundreds of pages of information that they sit down and they review with you and talk about potential side effects. Again, there was theoretical at the point of testing humans. And then they give you something in your arm and you don't know if you got the shot or you got a placebo, which is just basically water that's safe to inject in your arm. And then they measure your blood and look at your antibodies over time. And so each one of the companies that we have that are giving vaccine in the United States, Moderna, Pfizer, and J&J, did the same things. And usually the process for an FDA approved medication or vaccine is that process would take years. And the reason it would take years is to get enough people, and because the amount of disease in the community is so small that it takes a lot longer to measure it. But as many of you know, millions of people across the world were infected with COVID. So the ability to study the infection really helped us speed up the trial. So no steps were missed in that way. The other thing that is unique about the vaccine trials is they're using established technology like mRNA and viral transport. So the J&J is based on adenovirus, which is a virus that we get when we're kids. They used the type of virus that is not active. So they're not actually giving us the vaccine, but they shape it just like that. And then Pfizer and Moderna are based off of mRNA technology. All of that technology already existed for decades. So that is another step that sped up the process. They weren't creating something out of thin air and had to come up with, how are we going to make a vaccine? They had coronavirus already. Like, coronavirus is a virus that exists in the world and lots of people have had it. So a lot of the steps were sped up because of all of that information we already have. And then the last process that I think is really important for everyone to understand is the process of emergency use authorization, also referred to as EUA. And if you think of the FDA, so the FDA is our federal body that reviews all sorts of medications and things that enter our body, like immunizations and medications and cigarettes and all sorts of things. Usually you get in line. So let's say Dr. Gupta or Dr. Mani come up with a medicine that they want to try on people. They'll get in line. They might be 50th in line. They might be 100th in line. They might be 200th in line. And then you wait your turn until the FDA has time to review it. And then they might assign a person or two, and that person will spend the next year looking through all your data. Well, what we did with coronavirus, because this is a global pandemic infecting millions of people, is they took that trial, or that individual from 50th or 100th in line, and they moved them all the way up to the front, and they committed extra scientists to review all the data and to make sure it's safe. So the EUA process is a way to expedite, because it is important on a population level, not because any steps were skipped. It was still found to be safe, and there were thousands of people who continue to be in the trial. So they're still testing our blood. They're still looking at how we're reacting to the vaccine, whether we need boosters. That's why we know the booster recommendations, because those of us in the trials are still getting our blood work done for the amount of protection we have. So the trials were actually, and have been done in large communities. But the other thing that's a reality is that millions of people have now also been vaccinated. So we have all of that data as well. And that's why we know these vaccines are very safe and they work very well, because millions of people around the world have gotten them.
Great. Thank you so much for walking us through this process. Dr. Mani, as a mom, and I represent the thousands of parents out there who have concerns, especially in our area. We heard about myocarditis in the 12 to 15-year-old kids, despite the promise of nearly perfect protection. Can we expect that in younger kids as well? And on a more broader side, what side effects were seen with the vaccine in the trials?
That's a great question. So I think a lot of people are understandably concerned that in the clinical trials for adolescents, there was not a lot of myocarditis seen, but in the post-authorization monitoring period, there were reports of myocarditis appearing. And what we know is that very rare side effects, extremely rare side effects, will not be able to be detected until we've vaccinated millions of people. But what we do know is that this certainly is not a common side effect. And it also, in the real world review, has shown to be a relatively mild side effect in most kids or adolescents who have experienced this. Myocarditis in general, which is inflammation of the lining of the heart or the heart muscle, it tends to occur more commonly for a variety of reasons totally unrelated to vaccination in adolescents and in younger adults. It's extremely rare for myocarditis to occur in the 5 to 11 age group for really any reason. So we believe, one, in the clinical trial data looking at children ages 5 to 11, there were no cases of myocarditis seen. So one, we're reassured that it's certainly not a common side effect. Two, we know that it doesn't tend to occur that common in this age group anyway. But three, we will really have to see once the vaccine is distributed to millions of people, what rare side effects may occur. Interestingly, the risk of myocarditis from COVID, which I think is not talked about as much, nearly as much as the risk of myocarditis from the vaccine, it's like 20 times higher than the risk of myocarditis from the vaccine. So I think, looking at the statistics, it can be really hard to really put things in that big picture perspective. But for that particular side effect, we feel pretty reassured. And then just in general, talking about the safety profile of these vaccines. So the purpose of the clinical trials, and this specific clinical trial in children, was to determine, is the vaccine safe? Is it effective? And does it produce a lasting immune response? So safety was a major priority in this trial. And the data is very, very reassuring. I think it's natural for parents to be concerned about what they're putting into their children's bodies. But the side effect profile was actually very similar, if not a little bit milder than what we see in adults. So injection site pain was the most common reaction experienced. Fatigue and headache were also commonly experienced. Fever was seen in less than 10% of children, and no serious adverse events were reported whatsoever. The only adverse event that was not really related to vaccination was a broken arm in a child who got vaccinated. So not related to the vaccine, but that was the only adverse event experienced by children. So I think that all of this data is public. And so I encourage you, if you have an interest in looking at the primary data, looking it up yourselves and looking at some of the graphs that show you the kinds of reactions people experienced, and also the reactions that people who got the placebo shot experienced, which is always just an interesting thing. I think when I get vaccinated, yeah, maybe I might feel like I have some symptoms that are kind of hard to gauge if it's really related to the vaccine or not. So
it's funny you say that. As I mentioned, I was in the vaccine trial and they do what's called blinding. So they didn't tell me which one I got. And so I felt great. Honestly, I had no side effects. And then they had to unblind me because I'm a healthcare worker. And they were like, but you got the vaccine both times. I was like, well, there you go.
Great. That's very reassuring, Dr. Mani. Dr. Gupta, we hear about waning immunity in adults and they require a third dose now. Will the same thing happen in kids? Will they need annual boosters?
Dr. Chopra, I have to say, not to confuse anybody on this call, because that's the last thing I ever want to do, especially in this era where I think there's been a lot of confusion on health messaging. But I will say that if you are otherwise healthy, less than 65 years of age, regardless of what the headlines are suggesting and what the FDA will or will not approve, it is likely that even if everybody who got 2 shots in the United States already will be eligible for a 3rd shot, Whether they need it is an entirely different question. And the data is what the data is. And we know from a really large trial published by the Department of Health from New York State, looked at 9 million adults who got 2 doses of one of the mRNA vaccines and looked at their antibody levels, looked at their protection from ending up in the hospital because of exposure to the Delta variant, for example. They looked at all the stuff that we care about. And what they found was that even after 6 months out, no one was really ending up in the hospital. That protection against severe outcomes, even in a younger age group, was really robust. And so I'm worried that this rush to boost everybody, even those that are not high risk because you're over 65 or because you have a high risk medical condition like chronic kidney disease on dialysis, or you have a recent diagnosis of cancer, something very serious medical condition, that we're now talking about boosters for everybody. And it's really confusing the purpose of vaccination, which in my view is to keep you out of the hospital, prevent serious complications. And we know that for the majority of people that are otherwise healthy, less than 65, 2 doses is still sufficient. And I think it's important to recognize that and feel reassured by it, because it matters for these discussions that you just posed, Dr. Chopra. What about my kiddos? What about 16, 17-year-olds that are sort of in that older adolescent category, but not quite yet adults, since we define adulthood by 18 and up? All these questions are now arising, and yet 2 doses still seems robust. So it's all to say, for the parents out there, do I think a 3rd shot will inevitably be recommended at some point down the road, into 2022, early 2023, a year plus out from the initial series of 2 doses? Perhaps. But we're still waiting and seeing. And I think it's important to recognize that 2 doses for the vast majority of people that have already been vaccinated is sufficient for the reasons of keeping you out of the hospital. And I'll lastly just say, this matters because we're still, IHME is projecting at the University of Washington, we're still going to see 10,000 weekly deaths amongst our fellow Americans well into the winter, largely, overwhelmingly amongst the unvaccinated. And I'll say, just having talked to my colleagues in the military and other organizations, one of the things they keep pointing out is, well, why do you need a booster? Why do we need a 3rd shot? Where's the data to back that up if the end goal here is to keep me out of the hospital? I worry that we're losing sight on the end goal here, which is to vaccinate everybody and to clarify messaging on the purpose of vaccination. So there are consequences to talking about boosters for all when the science doesn't necessarily line up, in my opinion. But for parents out there, for your kiddos, we're talking about kids, 2 doses for now, TBD on that 3rd shot, probably sometime down the road, but not something you need to worry about. And with the one exception being if your child's immunocompromised, where I'm sure the recommendation will be, as it is with adults, for a booster sooner rather than later. But of course, talk to your pediatrician.
Could I just add, that was great. I just, as a pediatrician, please don't ever promise no more shots. There's always another shot. It could be a flu shot. It could be a tetanus booster. So just never promise.
So the next question is for you and is also on short. So I know that this is a pet peeve of yours. So I'm getting my kid the COVID vaccine. Should I hold off on other immunizations for her? Dr. Bell.
Oh, sorry. I was just making sure. That is a great question. So one of the things we found over the course of the last 20 months is that kids started to fall behind on vaccines. Over 40 million children in America are under vaccinated. Part of it was for good reason, right? We were saying, hey, don't go to the emergency room, don't go to the doctor in the initial months of COVID if you don't have to, because that's where sick people are and you don't want to get COVID. Now that we know how COVID is spread, now that we know that masks, vaccination, hand washing, social distancing is really helpful, it's very safe to return to your medical clinic and start seeing your primary provider. And we really want to encourage people to get their children caught up on vaccines. And what's really great is that part of the vaccine trials and part of the work that the CDC has done is to make sure to measure, to test, including on those of us in the vaccine trials, is whether it's safe to get other vaccines at the same time. And the data has been overwhelmingly positive. It is perfectly safe to get multiple vaccines at the same time. You do not have to space them out. You can get your flu shot and your COVID shot. You can get caught up on your childhood immunizations and your COVID vaccine. And in fact, I'm really encouraging folks, and we're doing it at our clinic at Odessa Brown, is trying to offer as many shots as somebody is due for while they're there to really save on transportation, taking off work, trying to get an appointment. Why not? Like, let's take care of you while you're there and get you taken care of and get your kid up to schedule with their vaccines.
So as Dr. Bell pointed out, there are no interactions between this vaccine and others. So it's perfectly safe to go ahead and get your vaccinations and get your kids their vaccinations. Dr. Mani.
Yeah, I was going to say, I completely agree. We should never waste an opportunity to vaccinate. And there also is a little bit more data in this sphere as well. There was an interesting study published in The Lancet recently out of the UK, where they looked at people who were getting their second dose of their COVID shot and randomized them to also receive their flu shot at the same time, or a placebo shot. And they found that the reactions were the same in the two groups. So people who got both shots were not having more serious adverse reactions. And then they also found that the antibody response to both of those infections, to flu and to COVID, was still preserved. They were still producing a good immune response to both. So I got my COVID booster and my flu shot together. I got one on each arm. And I'm feeling reassured that there's more and more data to support that.
Awesome. Dr. Mani, since the COVID virus mutates, should we wait to see if a better vaccine with more coverage will be developed? And I'm asking all these questions in the first person because that's how they are sent over to us.
Great. So I'll reiterate what I just said. We should never waste an opportunity to vaccinate. And I would take whatever vaccine is available to you right now, and not wait for something in the future. I will say that while we are seeing more breakthrough vaccine infections now with Delta, maybe than we did previously, as Dr. Gupta already mentioned, the vaccinations are extremely effective at preventing against severe disease and hospitalization, even with Delta. So this really tells us that the vaccines that we currently have available are doing what they should be doing, even against the variants that we currently are seeing. Only time will tell what is in the future. And certainly as long as we have communities where there are lots of unvaccinated people and where the virus has the opportunity to mutate, we will kind of see what new variants may emerge and what type of vaccine protection is still afforded. But at this time, we feel very confident that the vaccines that we have available are effective against the Delta variant, against the most important outcomes, which are hospitalization, severe disease, and death.
Okay. Dr. Gupta, the next question is about natural immunity. Can you please tell us about natural immunity? And someone who has asked the question says, I know many vaccinated people with breakthrough infections, but I don't know anyone with natural immunity having a repeat infection.
Absolutely. And since I apparently have the ability to screen share, I'm going to, if my co-panelists don't mind, instead of me yammering away, I'll share a slide that I have on the ready. And I'm sure Dr. Mani and Dr. Bell can elaborate. Luckily, this is a question that has been top of mind. I've heard it from the very get-go. If you've been exposed, well, doc, and you've survived, do you need to get vaccinated? Do those natural antibodies in your bloodstream, are they sufficient to protect you? Do you not need to get the vaccine in that case? And, we've thought from the very beginning of our vaccination process that, it's still really going to behoove you to get vaccinated. The antibodies your body will produce will be even higher in amount. They'll be more powerful. They'll protect you more strongly against the Delta variant, whatever else arises. And now we have data that has been now serially published in one of the best journals produced by the US Centers for Disease Control, the Morbidity and Mortality Weekly. They produce a series of real world studies showing that if you assume you were protected because you were exposed and have survived COVID and decided to opt against getting vaccinated, well, your risk of ending up with serious illness from COVID, ending up in the hospital, is almost 5 times higher than those individuals who are fully vaccinated. And this is a study that was actually just published October 29th of 2021. I can't tell you how valuable it is to actually have hard data, multiple studies looking at this specific question, because this is top of mind, and I get it. I think that it's not unreasonable for people to probe on this and to ask, well, gosh, if I recover from it, aren't I protected to some degree? The answer is yes, to some degree you are. It's just not nearly the type of protection that you're afforded if you decide to get fully vaccinated. You are putting yourself at undue risk. And now we actually have the data to back it up.
So, Dr. Gupta, the takeaway point is that even if a child has had COVID, they should still get the vaccine.
And thank you for the so a lot of all the studies I just showed were amongst adults, and yet the generalizations here we suspect will apply for children as well, that natural immunity, while protective to a certain degree, does not connote the same level of protection as being vaccinated will provide you in terms of the risk of reinfection, ending up in a hospital. So yes, this absolutely still applies to a pediatric population, even though these studies were technically done amongst adults, that same line of thinking applies. And I'll lastly just say that there's so many unpredictabilities about natural immunity. That's one of the other take homes here, why you should get your kiddos vaccinated, even if they've recovered from the virus previously in the last 20 months, that we don't know how long those antibodies will circulate in their bodies. In some cases, some individuals lose those natural antibodies in a matter of months, a few months in some cases. It's clear that those antibodies, also those natural antibodies, and if, forgive me, I will yield my additional time hereafter. It is also clear, if you can see this schematic, that natural antibodies are not as good, whether we're talking about a kiddo or an adult, at blocking this key interaction between coronavirus here and basically the docking stations on our lung cells that allow coronavirus to interact with our lung cells and then ultimately cause infection and cause pneumonia. Natural antibodies cannot block this interaction nearly as well as the antibodies from the vaccines. And that's just Mother Nature. I can't explain why Mother Nature has made that so, but that's the way things are. And so for what's happening under the microscope, for the real world studies that now we have published amongst adults and what they mean for kiddos, there is no, you're taking a risk, an undue risk, by assuming that natural infection is all you need and recovery from natural infection is all you need to protect you. That is just a false assumption at this point.
Thank you.
I'd love to just add also that in the pediatric clinical trials for children's ages 5 to 11, there are about 9% of kids in there who had COVID. So I actually think it's really great that they included those kids and did not exclude them, because it helps provide additional safety data in that population. And that really showed that the safety profile was equivalent. And not surprisingly, the immune response, the antibody response in those children was more robust, and it was better than in children who had not had COVID and then gotten vaccinated. So that's similar to what we've experienced with adults as well. The best thing you can do is probably get COVID and then get vaccinated, but we don't want you to get COVID. But if you've already gotten COVID, getting vaccinated probably provides additional support there. And then just to answer the question about why we're seeing more people who are vaccinated get breakthrough infections compared to people who have had natural immunity, that is a very interesting question. I think that because we have so many more people now who are vaccinated compared to people who have had infection and have had natural immunity, the data is very skewed. The absolute numbers of people that we are going to see with COVID who have been vaccinated is much higher than the absolute numbers of people who have had natural immunity get COVID, if that makes sense. So as we vaccinate more of our community, King County, we're like 85%. As we continue to vaccinate more, we will see more breakthrough infections in vaccinated people, just because our denominator of vaccinated people is higher.
Thank you, Dr. Mani. It's very helpful to know that there were kids who had COVID and were enrolled in the trial, because that was one of the questions. Dr. Bell, this is a really good question. My daughter is turning 12 in a few months. Should I wait to give her the higher dose, or should she get the lower dose?
It's such a great question. You're absolutely right. And I encountered it just today. Our clinic is doing walk-in COVID vaccines for all ages that are eligible. And I personally did about 10 this afternoon before I left work. And one of them was 11 going on 12. And so we had this conversation. I think in all reality, I think it really is about getting the vaccine and getting protected as soon as possible. I think if it were my child, I would vaccinate them because I want them to be protected, because they're going to school, because the holidays are coming up. There's a million reasons I would give them the vaccine. As Dr. Mani has already said, the trials are phenomenal. It's a very safe vaccine. It's a very effective vaccine. It works. So let's get them protected. I think if they were turning 12 next week, I might think about waiting, maybe, but still the second dose would be at the 12-year-old amount and the first dose would be at the 11-year-old amount, and probably be fine too. So I don't think it's necessary. It's a long way of saying it's not necessary to wait. Both doses are very effective. And the reality is, just like we've already said, there's been thousands of kids in these trials, and some of those kids happen to turn 12 during the trial. And we know that it works, and the vaccine works at all ages. So I say get the vaccine when you can.
And the same goes for if they turn 12 between the first and second dose, then they get the higher dose.
That is correct.
Yes.
So you get so there's only 2 doses, although right now there's 3 vials, but 2 doses. One is from 5 to 11-year-olds, and that is about a third of the dose that is for 12 and up. And the 12 and up goes forever. The oldest person I vaccinated was 97. That's all the same dose. The 5 to 11-year-old is about a third of what the adults or 12 and overs are getting. It's the same stuff. The liquid in the syringe is made up of the same thing. The vials that come are actually color coded, so we'll make sure we get the ages right, and then we have to put dilution in there because they're concentrated, and so the amount that we dilute is a little bit different. From the 5 to 11-year-old vial, we get 10 doses, and from the 12 and over vial, we get 6 doses. And part of this early push was vaccine supply. We're getting in a much more stable place for all ages. That's one of the reasons why our clinic, for instance, is opening it wide up, because now we have reliable supply, and we know that we'll have a dose if somebody needs a dose.
And then, Dr. Bell, what would you say for kids who are 4.5?
Well, officially, I have to say you have to wait till you're 5. I will say that they are currently still enrolling in the vaccine trials of 6 months to 4-year and 11-month-olds. So that gives you a little bit of an idea of how long or how far out we are until that vaccine has an EUA or a full approval from the FDA. It's going to be a while. I do like Dr. Gupta's ability to hedge our bets. I think trying to predict COVID, anything in the time of COVID, whether a booster will be a year or 2 years, it's tough to say, right? COVID has certainly kept us on our toes if it's done anything in the last 20 months. So it's likely that the younger childhood vaccine will be out in spring, summer, but we just don't know. They are still enrolling in the trials. That means the trials are still active. We haven't even had enough time to gather the data yet. So tough to know exactly when, but it is under review.
Dr. Mani, I know you talked about this a little before, but some people have heard that the Moderna vaccine is better, quote unquote, better than the Pfizer. And should they wait for the Moderna vaccine to come out for kids? Or should they, like you said, go ahead with the Pfizer now?
Great. So I think Pfizer kind of won and got to the finish line first. So right now we're dealing with Pfizer. I think if your child is eligible to receive a Pfizer vaccine, I would absolutely do that right now. Moderna did release a press release on their data in children ages 6 to 11 who received 2 doses of the half adult dose. 50 micrograms, which is also the same as their booster dose, and had very positive results, very good efficacy, and really great immune response. And so I think we will hear more from the FDA on that soon, and I think we will likely see that children will end up being eligible to receive Moderna as well. But right now, I would move forward with Pfizer. I think this question comes up in adults as well. And there's so much choice right now with mix and matching boosters and so many vaccines. And we have really a whole menu in front of us, which is potentially more problematic than it is helpful. But I would, same advice, I would get whatever vaccine you can. You know, there was some data published in the CDC that showed that Moderna was possibly slightly more effective at preventing against hospitalization, especially in older adults compared to Pfizer. But those percentages were somewhere in the order of 93% for Moderna and 88% for Pfizer. So really not meaningful differences. They're both extremely effective at preventing against severe disease.
Dr. Gupta, there are some concerns about the ingredients in the kids' vaccine, and please, everyone, you know, all of you, please feel free to chime in to that. But I'm going to ask this question from Dr. Gupta. There is some concern that the kids' vaccine has tromethamine as an ingredient, which is dangerous for kids. And it seems that in Kitsap County, there are some flyers circulating about this ingredient. Is this a concern? And what should parents be worried about it?
Dr. Chopra, could you repeat the ingredient?
So there is a concern about tromethamine as an ingredient, which is a buffer used in the kids' vaccine.
You know, I'm actually going to defer to greater expertise here on the call. I'm sure Dr. Bell, Dr. Mani, you probably encountered this question more than I as an adult pulmonologist. So if you don't mind, I'm going to pass the buck here.
Sure.
I'm happy to take a first stab at this. I'll just first say that it's very scary to hear these things. And so I share the concern of parents and other individuals who are trying to learn about these vaccines and hearing a lot of things that might sound scary. This particular concern about tromethamine is, I would call it disinformation. It is a stabilizer used in the Pfizer vaccine to allow it to remain in the fridge for a long period of time, so up to 10 weeks. As you all may know, the mRNA vaccines are unstable and need to be kept at a very cold temperature, so this helps alleviate some of that. It is found in many household products, fragrances, cosmetics, lotions. It's found in medications like insulin, and it's also found in the Moderna vaccine. So I think it has a safety record, and it's kind of ubiquitous. And I believe that a lot of the disinformation surrounding this is really not valid. Dr. Bell, please feel free to add anything else.
Yeah, I mean, I have a lot of conversations about vaccine ingredients over the course of my career, as you can imagine. And I think what is really important to know is that we have never had serious long-term consequences from a vaccine. So we have been giving kids vaccines for decades, and we know that we learn early, usually in the trial, if not almost immediately, as Dr. Mani said, in terms of rolling it out in large populations, whether there's going to be a side effect or a serious complication. And I say that to say, because a lot of these ingredients, which I would need some vocal training on how to pronounce, are really scary in names, and they sound really scary. And sometimes you can Google them and find some very strong misinformation about it. The reality is a lot of these stabilizing ingredients are what we use in vaccines across the board. So as Dr. Mani mentioned, Pfizer has this, and they have it in all of their vaccine products. So it's not unique to this vaccine. And almost all of the ingredients in all the vaccines are that way. So you know, I would challenge us to say how many of us can pronounce every ingredient, everything that we eat, or every medicine that we take, or everything that goes in our body. Not to say that, you know, I want to be flippant, but the reality is there's been a lot of study around it. They're big names, they sound scary, but it is really safe. And we know that because of the science. We understand the way the vaccine works. It goes in your body. It kind of shows us a picture, kind of like how we learned how to read and write. Our body goes, oh, okay, that's how we fight this virus. And then the vaccine goes away. None of those things stay in your body. Your body dissolves all of those things and they leave. And all you're left with is the memory, the ability to remember how to fight that infection. So that's the key I like to share, is that even if that ingredient scares you, or you don't know what it is or why we use it, it's going to leave your body. It's not going to stick around. So you don't have to be worried about it, or you're welcome to read more about it, just not on Google, maybe. No offense to Google.
So this is not something that is unique to this vaccine. It has been there prevalent in other vaccines as well. So it's not something that is being introduced for the first time. Dr. Mani, how can we report side effects from the vaccine?
It's a great question. I love this one. So there are two different reporting tools that you can submit to with the CDC. One is called Vsafe, which I actually encourage all of you to sign up for. You can sign up on behalf of your children. You can enroll them. It's a smartphone-based tool where they will reach out to you with text messages and surveys, checking in on you post-vaccination, and give you the opportunity to report any symptoms that you might be experiencing, whether it's mild symptoms or more severe symptoms. If you do experience something more severe, someone will reach out to you. And I will say that the Vsafe registry is one of the most important ways that we have been able to get safety data on pregnant women, because pregnant women were not included in those early clinical trials. And we've now had thousands of women who have gotten vaccinated during pregnancy enroll in Vsafe. And we've learned a lot about the safety profile, essentially learned that the vaccine is very safe in that population through that method. The other tool that you can use is something called Vares, Vaccine Adverse Event Reporting System. That is really only used for more serious medical conditions that may occur in the weeks following vaccination that may or may not be related to vaccination. And either you or your healthcare provider could submit a report to the CDC if something like that does occur, which we don't expect that to happen, but definitely encourage you to check out Vsafe.
Thank you. Dr. Gupta, will one dose of vaccine be enough for my child, or does he really need both the doses?
You know, it's a question that was asked often amongst adults who, for example, as Dr. Mani had pointed out earlier, if you got COVID, you recovered. There were some studies suggested that one dose was enough to really get you fully vaccinated, that combination of recovery plus one shot was sufficient. Of course, we recommend everybody still get a full series because that's what's been studied and that's what we feel really confident in from a data standpoint. For kiddos, there is no strong evidence that just one shot is sufficient. It just hasn't been studied. The long-term protection afforded by just one shot of the low-dose Pfizer shot in this case. We're still waiting on taking a deeper look on the Moderna pediatric vaccine, but there just isn't enough data on looking at one shot of Pfizer because they didn't study it over a long period of time. Everybody that got that first dose of Pfizer in the clinical study that was just published ended up getting the second shot as part of that series. And so we just don't know. And so there's that uncertainty there, which is why, as with adults, we're still recommending that everybody 5 and up get 2 shots of the vaccine because that's what's studied, that's where there's certainty on the data, that's what's known.
Dr. Bell, is there any data available on the post-vaccine antibody titers? Should that be measured as a routine in kids, the antibody titers?
That's a great question. So because the trial just completed, they have not released that data yet because the initial phase of the trial just completed. I will defer to Dr. Mani because she has like all these studies pulled up if she sees any data, but I haven't seen any for kids. We've had some for adults. That was pretty convincing. The other thing I'll ask us I just want to be mindful of time. The most common question I've gotten this week is about travel for holidays. So I thought I might just chime in really quick. If you're getting in a car and you're going somewhere, you're vaccinated, they're vaccinated, have fun. Happy Turkey Day or whatever you celebrate. Hanukkah's coming up as well. If you are getting on an airplane or if you are flying to a place that has a lot of COVID right now, or you're visiting people who are unvaccinated, I think it is really worth considering whether that trip is taking from a parent, and a kid told me this, our debt calculator. So our risk calculator, excuse me. So we want you to pull it out and say, hey, I'm going to get on a plane, but we're all vaccinated and I'm going to wear my mask and I'm going to be as safe as possible. And the place we're going, everyone is vaccinated. That's probably a risk that I would be willing to take right now. I'm not going anywhere, but that's okay. I have a really lame life full of vaccinating people all day, every day. However, if I was going to get on a plane and go to one of the cities that's on Fox News all the time, I might not do that because the rates of COVID infection are so high right now. Or certainly if I was visiting a family member who was unvaccinated, like children under 5, we are not recommending, and the CDC has been pretty clear about this, that a child who is not able to be vaccinated should not be traveling via airplane right now, because Delta is so serious, and because our rates of serious complication and hospitalization are in the unvaccinated. That is the group we're the most worried about, and kids under 5 cannot be vaccinated. So we need to protect them. So I'll just throw that out. It is great to have a conversation with your healthcare provider and really think about what are the risks, who is vaccinated, how are we traveling, and where we're going.
Dr. Bell, can you also add a little bit about masking? Because that was the other question. Can I relax on masking now that all of us are vaccinated at home?
Let's all take a walk down memory lane and remember back in June when we were like, yeah, take your masks off. You're vaccinated. No big deal. I'm not taking my mask off anytime soon, indoors or anywhere where other people are at, where I don't know their vaccine status. And I'm not walking around asking people their vaccine status. So I'm at home right now. I have my mask off. When I am at work, I work in a hospital at Harborview and I work at a clinic at Odessa. I will always have my mask on, whether I'm going to the bathroom or seeing a patient. I think, the guidance has been back and forth. And I think to Dr. Gupta's conversation, I think we have not done the best job of clearly communicating. And there's been some walking forward and walking back. And we all know walking back is really challenging, especially if you're trying to chew gum. So that's a really long, circuitous way of saying, I think if you're vaccinated, it's probably fine to take your mask off outside. If you're vaccinated and you're going to be indoors around people whose status you don't know, or you're in like a healthcare place or an airport, I would still keep my vaccine or my mask on. Geez, vaccine and mask, keep them both on.
In the interest of time, I'm going to direct to Dr. Gupta. Can you please talk a little bit about the new COVID pills that we are all hearing about? And would it be available for kids as well? Can you please talk about the pills?
Certainly. So I'm sure many of you have heard about these oral antiviral pills developed by Pfizer and Merck that have been consuming a lot of the media headlines. Essentially, for those who are deemed high risk. So think about the same framework that we talk about high risk adults who were first in line to get the vaccine, first in line for the booster. So you're older in age, 65 and older, or you have a high risk medical condition like cancer. These are the individuals, sort of that 60 and older crowd that were studied in these trials that looked at the effectiveness of these therapeutics developed by Pfizer and Merck. And what they found is that if you qualify as high risk and you're diagnosed early with this virus in the first 72 hours, ideally, that if we give you this medication, intervene early, give you this 5 days of this therapy, interchange Pfizer or Merck, that the risk of you then ending up in the hospital with severe COVID, and let me remind everybody that everybody in these trials were unvaccinated, the risk of you ending up in the hospital was dramatically reduced. In the case of Merck, that that risk reduction was 50%. In the case of Pfizer, it was extraordinary. It was 90% reduction in a high risk unvaccinated individual treated early for ending up in the hospital, pretty much stop progression of the illness. We don't have time to talk about the mechanism of it, but needless to say, especially the Pfizer therapy can revolutionize how we treat this virus. And really, I think its implications for global health for lower and middle income countries is extraordinary, where vaccine rates really leave a lot to be desired because of access. And so it's all to say that this medication likely will not be available to a pediatric population for the foreseeable future. I would make an exception likely for the high risk, so immunocompromised children. I'm sure there will be exceptions for that specific group, but for everybody else, this is going to be a therapy that will be targeted to high risk individuals broadly, and that's usually defined by either you have a high risk medical condition or your age. And so, just given the nature of our population, that's really going to apply to adults 60 and older, most likely. The FDA is going to review the data on this medication in the next week or so, so we'll have clarity on who's really eligible. But we're supply constrained. We just don't have enough of this medication in the coming months. So that's why it's going to be really limited who can get access. And of course, we want as many doses as possible to be given to other parts of the world that really need it.
Thank you for that information. Dr. Mani, a quick question about allergies. Kids who have severe allergies, are they okay taking this vaccine? And also, do they need any pre-medication before the vaccine?
Yeah, great question. This answer, I think, is the same for pediatric patients as it is for adults, which is that if you have food allergies, allergies to nuts, to shellfish, to any other non-vaccine substance or non-COVID vaccine substance, you are safe to get these vaccines. And we really have not seen adults with food allergies, even severe anaphylactic food allergies, have hypersensitivity reactions to the COVID vaccine. And Dr. Bell, please feel free to add anything else you might have shared with your patients.
Yeah, absolutely. And no pretreatment is required. Any location that's giving the vaccine will have access to epinephrine in case of an emergency, but the anaphylaxis rate or serious allergic rate, that's another word for anaphylaxis, is less than 1% of 1%. So it's really super uncommon. And we haven't seen, there's no data to suggest that's any different in kids, and really the science wouldn't pan out either. It wouldn't make sense for kids to have any different reaction than adults.
And then Dr. Bell, for kids who are on chronic anti-allergy medications like Zyrtec or Claritin, would they be okay getting the vaccine, or would that medication interfere with the vaccine?
Good question. Again, the science of the actual mRNA and adenovirus vaccine, that's not the way it works. So it's totally okay to be taking your allergy medication. It's perfectly safe, and there's no data to suggest that you have a different immune response. As we mentioned, thousands of kids were enrolled in this trial, and some of them were taking Zyrtec and Claritin. And they just, that's one of the cool parts of doing a trial, is you get to see, kids who are big and kids who are small. Another question I get is, does it matter how much my kid weighs? So the sample of kids who participated in the trial also have all those things. They also have allergies and food allergies, and weigh as much as their older brother or sister, or weigh as much as their little brother or sister. And the data is really, really clear that all of those things are perfectly safe. So good question. And in all of these questions, if you're taking a medication or you have a condition that you're not sure about, it's always great to ask your healthcare provider, to have a conversation, and just make sure that all your questions get answered.
Thank you so much. And that brings us to the close of this session. I think we had some awesome questions from the audience, and thank you so much to our wonderful panelists for the great answers and for giving us so much information. And especially, it means a lot to us as parents to hear from our experts and to hear that the data around the vaccine is very reassuring. Thank you very much again, and over to Priscilla.
Thank you all also for joining. I did put in the chat the link where this recording will be uploaded in the next couple of days if you'd like to share with your family or friends that couldn't attend tonight. This will also be uploaded to our UW Medicine YouTube channel in the next coming days as well. So you'll be able again to share this. But again, thank you for joining us, and we'll see you next time.